I think this is one of the more challenging areas for an oncologist and a patient, a family, is when a patient's done very well on a drug like erlotinib or even chemotherapy, but in the case of an oral therapy, erlotinib or crizotinib, someone who's been on therapy and just done beautifully, the cancer's been in control, they've not really had side effects, and the whole experience of treating cancer has not been what patients and families have expected. It's been easy. And then things start to change. You walk into a room and you get that terrible news that, you know what, I think this is not working as well as it used to. There are different scenarios, I think, when someone progresses or has cancer progress. I think there are these situations where there's technical progression. So by measurements, we have to say that there's more cancer than there was before, but it's not what we call clinically significant. In those circumstances, I think it's worth giving a patient the benefit of the doubt and continuing that therapy and watching them closely. I mean, I think all of us can describe experiences where that has paid off for patients, where we've squeezed out, so to speak, several more months of care in the way that they were receiving it prior to that. I think there are other circumstances where the progression or the new cancer is more dangerous. For example, a patient who discovers there's a new spot in the brain or several new spots in the brain. I think there are situations there where you can put those fires out, so to speak, with radiation therapy, sometimes to the whole brain, sometimes in what we call a selective fashion, sometimes even with 1 day of treatment. I think in those circumstances, staying on their oral therapy like erlotinib or crizotinib is reasonable, but even in those patients, you have to watch things carefully because that could just be the tip of the iceberg. And then I think there are other circumstances where patients have a lot more cancer. And in my opinion, at least right now, I switch therapy. So I do understand the rationale for continuing that therapy that's helped patients before, but I tend to switch patients, and selfishly, it's often because I have a research or trial opportunity for a patient where staying on that pill is not going to allow them to have the opportunity to go on to something else on a research basis. But if I didn't have a research opportunity, I still would switch them to some other standard, in this case from erlotinib to chemotherapy. Now, I certainly have had regrets where I've thought, boy, I'll just take some time and we'll do carboplatin and pemetrexed, for example, and then we'll come back to a drug like erlotinib. Maybe after several months, this cancer will forget erlotinib and it'll be sensitive again. And I think all of us have had those experiences where that's worked too. But for most patients, at least in my experience, that doesn't last very long. So when you go back to that oral therapy, a therapy that worked so well before, maybe even for over a year or two, going back on it, at least in my experience, has not always been as rewarding. And often it's a temporary, very temporary bridge to returning back to another chemotherapy or research opportunity for patients. It's a very challenging area. You know, here we are very excited about the opportunities for an oral therapy that can do wonderful things for patients, but we know that these therapies are not good enough to cure patients. How do you handle a patient who does well for 5 years on a therapy or someone who does well for a year? It's really a challenge.